think Glenda is online for a discussion. I have a question for you. Did you check the maternal deaths in Holland to see if you had any suspect deaths in patients, maternal mortality statistics? Did you do that to find the patients you didn't see here?
Is it working? Yeah. Yeah, that's a good question. We have looked in our entire cohort studies and in the families of the included individuals, and we did not see any suspicious deaths in women around the reproductive age or during the delivery or the first year after delivery. No.
In France, there's a statistics department. They do only that. They monitor suspect deaths or maternal deaths, and we can sometimes we can study these to find eventually patients that are being suspected of vascular EDS without being diagnosed.
Oh, we don't have that kind of database that I'm aware of. No.
I'm also not aware about such a database in Netherlands, but thank you for the tip. We could definitely have a look. Yeah.
Peter Byers, I wonder, have you made an effort to try to stratify your approach to pregnancy in women with vascular EDS, at least by taking into account the nature of the mutation that's present? And it looks to us, or looked to us certainly, as if those who have heterozygous nulls have a very different, I mean, just as they do for the rest of their history, have a different response to pregnancy. And from looking at some of the families, there are no history of complications in some of the families with substitutions by alanine, for example, for glycine residues, and in some instances, serine substitutions have had no complications for multiple pregnancies among women. And how do you think about taking into account that in terms of stratifying the approach so that they can go on to have term deliveries and vaginal deliveries if they want to, as opposed to C-sections?
Yeah, I think that's an important question, and I think it's important to stratify for the variant category. As we see that individuals with a haploinsufficient variant had quite little complications. Most complications that we have seen in these women were perinatal tears because they had a vaginal delivery. So if you would perform a cesarean section at 36 weeks, for example, then we won't have that complication either. So I think it is important to look at the variant category that is present in a patient to decide whether or not we have to discourage a pregnancy. And I think this data might suggest that individuals with, for example, an haploinsufficient variant, I think they might can get pregnant safely with good monitoring and a cesarean section.
Same question for me?
Okay, I will ask.
Glenda, do you wanted to answer to that question?
As it turns out, none of the patients whose pregnancies and deliveries we have managed were haploinsufficient. So that wasn't a consideration for us so far for these 12 patients. A slight difficulty with obstetrics is that allowing people spontaneously to go into labor sort of takes away any additional, putting any additional safety measures to delivery by any means. So I think that even in that group of patients, our obstetricians would offer them an elective cesarean section. But as I say, it just hasn't come up for us yet.
Just a quick answer for us. We didn't do the stratification yet, but these data I've shown are not published. These are from 2014. We're currently updating the pregnancies we have, and we try to do that the same in France, and we will look at the haploinsufficient patients. These were only dominant negative ones to better define outcomes. After, it would be a problem of numbers. So maybe registries, or by putting together these data, it could be easier to identify, not for haploinsufficient, but for residues, outcomes, or possible stratifications of risk.
In the meantime, there's also, or would you like to comment on? No. There is also a question from an anonymous online attendee. How do the pregnancy delivery guidelines for vEDS, vascular EDS, apply to the other rare types of EDS with vascular involvement? So if maybe Glenda or someone else would like to comment on that. Do you have any thoughts about that, Glenda?
In classical EDS, we are always in touch with the obstetric teams, but we don't follow the same set of guidelines that we do for vascular EDS. In the other genetically defined types, really the numbers of patients who we look after are very small indeed. So it's hard really to give any advice beyond that. But I think what we would always do is make sure that the teams were very, very well aware of the diagnosis, exactly what it entailed and what the risks, including vascular EDS vascular risks were. And obviously, for instance, the group of kyphoscoliotic patients are a group of patients who are similarly seen by our specialist cardiologists and are imaged. So we would be aware of anything for the individual, really. I must say the one thing that the pandemic has brought us that is good is the tremendous availability of Teams meetings. So we can easily get together large groups of specialists from anywhere in the country. In fact, this week, one of our patients in Scotland is to be delivered, and we had a Teams meeting of 15 of us. So every single person, ourselves and every single person in Scotland involved. And those sort of things can happen at very short notice. And so we'll do that anywhere just to make sure that the diagnosis is understood. But I think really the chances of developing any sort of evidence-based guidelines in the very rare genetically defined types of EDS will be hard to make general rules, but rather something that will need to be personalized for the individual.
So are there any more questions? I'll tell you later. I have to look it up. I have it written down somewhere.
Would it be possible to make a list of all the studies? I mean, it's very interesting. It's remarkable how different the experience is in different centers, which is probably mostly, or part of it is chance, part of it may be difference in what type of mutation there is, what the recommendations are. So I think it would be really nice if we try to get all the cohorts together in one big combined analysis, because really we want to advise our patients what's your added risk. I mean, they have a risk, they know they can die with a probability of 2% per year, depends, and then what's the increased risk, because that's a personal decision. And we deal with risks all the time in genetics, but we do not have, you know, from looking at the presentations today, is it 2% or is it 8% more from the data that we've seen? But we should be able to get those data. Peter,
I'm glad you've asked that question, because we're trying to do that at the moment.
Yeah, for all centers in the whole world.
Yes, absolutely. Well, certainly for the centres who have documented experience in that, the plan is that each of the centres involved, and if there's anybody here who hasn't been involved in these discussions, perhaps get hold of Umema through the society. And the plan was that each group would seek individual research ethics from their own centre and put forward the cohort of their own patients, and then we would combine these across groups. I guess it's going to be mainly the larger groups who would have any reasonable numbers of patients who'd been carefully followed up for this, but that is in progress, but a little bit more complex than we'd imagined it might be. But certainly from our side in Sheffield and from our sister service in London, we are good to go with that work with our cohorts.
Okay, Cecilia Giunta, Zurich, Switzerland. Since you're planning, as I heard, this kind of study, putting together all the different cohorts, are you going to consider analyzing in the families the heritability of the mutation and checking if the mother of the index patient that you have carries the mutation, so it is known, and how is it possible that the mother, who maybe delivered 2 daughters or 2 kids, at that time, long ago, didn't have complication postpartum, and one of the daughter died. This is, for example, one case that we have 30 years ago, with the mother delivered 2 daughters, and the daughter had a C-section, and a day after delivery died of internal bleeding. Is that, just to think, is being affected and having from a mother who was affected is an increasing risk for 2nd and 3rd generation? For example, being exposed to some adverse factor during pregnancy?
Sure, but
Yeah.
we know, so absolutely, we'd really collect everything that we could on this, and very grateful for colleagues' input. But even if we look at our non-pregnancy data in vascular EDS, we have ascertained some people in childhood through significant events, and when we've looked back through the family, found that a grandparent, in some cases in their 70s or even older, with obviously exactly the same genetic change, is fit and well and would never have known that they had anything wrong with them. So the variability extends across all aspects of this very difficult condition.
I would just like to, as a final conclusion for this session, about the patient testimonial that we heard. So you saw that was a patient of mine. I didn't say much, but you saw me. I just would like to say that that whole adventure that she went through, that's already probably more than 10 years ago. So when we went to the ethical committee in our hospital, and then a second time, and she had a lot of complications, but there was very little information out there to start from. So just showing how important all these studies and reporting all these things is for these patients. So yeah, I just wanted to make that remark.
So if there are not any more questions, maybe we go on to the next session. That is with a patient testimony.
Yeah, before we go to the next session, Roberto, sitting next to me, has an announcement or a question.
Thank you, Francisca. I just wanted to take advantage of the fact that I'm here and that this very diverse international group, we do have a fellowship for interested individuals trained as MDs at our EDS clinic One of the donors has decided to fund a one-year fellowship. And if you know of any candidates, because I've tried to advertise it in different forums, we are not focusing exclusively on geneticists or on a person of a particular background, but if you know of people that want to have more exposure to pediatric EDS clinic, please have them contact me and I can send you the information about this fellowship. Thank you.